Dr. Shalin Shah. He's here. He will be talking on orbital imaging and orbitotomy. What subtle radiological clues guide us to the perfect results? Over to you.
So, good evening. I'll take you on a brief journey of regarding the confusions I used to have whether to go for a CT or an MRI. I think everyone has somehow faced this dilemma that which would be the best option before planning an intervention for the cases. So let's go case by case. So for cases of orbital mass, when would I prefer a CT over an MRI? So orbit has a lot of fat which provides an excellent contrast in comparison to the lesion. So CT is often a very good option. Let's go ahead with some of the cases. So this patient had a lacrimal gland mass which was previously biopsied and found to be pleomorphic adenoma, but it was never truly excised. So in such cases, a CT would be a good option because we can actually look at the bones, and such a large mass where we may need a bone window creation with lateral orbitotomy, it would be a good option. So on the CT, we can exactly measure where our bone cuts need to be placed for complete excision. Next would be such tumors, giant tumors presenting with where previous biopsy had shown inflammatory tissue, and here you can see some of the region where a previous biopsy may have been done, but an extensive imaging with the bone window had shown that there was erosion into the sinuses, and a coronal cut also shows invasion of the frontal sinus and invasion into the anterior cranial fossa. So such tumors, we actually need to be very careful when we go ahead with the biopsy. An incision biopsy may be fine where we take a deep orbital tissue, but planning an excision in such cases would require a neurosurgical team. Then we have another case, a lacrimal gland mass, 37-year-old male, where a prior biopsy was shown to be inconclusive. We can see on CT that there is some bony remodeling and there is expansion of the orbit as well. And a subtle clue that we found was calcification within the tumor, and a final incision biopsy showed adenoid cystic carcinoma. So the patient was taken for complete excision followed by adjuvant chemo and radiation, and at 6 months right now he is showing a stable result. So these calcifications can be picked up on CT, and hence it would be a modality of imaging over MRI in such cases. And then we have some weird cases where repeated prior biopsies, 3 prior biopsies had shown pleomorphic adenoma with recurrence again and again. And here we went ahead for a CT because it was a giant mass, as we can see, occupying the entire orbit, expanding the orbit. And we can also see that it's eroding into the middle cranial fossa, eroding the greater and lesser wing of sphenoid and eroding the frontal sinus. So these tumors definitely need a CT because here we would like to delineate our margins of resection before going for a surgery, and such cases again need to be planned with a neurosurgical team. Then these are the tumors where both a CT or an MRI may be helpful. I would prefer a CT in this kind of a frontal sinus mucocele. He had a prior history of FES. Why I would prefer a CT is because the bony window shows some amount of erosion of the orbital plate of the frontal bone, and hence a resection of this via transconjunctival or a trans lid approach, vertical lid split approach, would require careful dissection of the roof of the orbit. And so this was one of the challenging cases who had presented to us with failed external DCR twice, and when we did an imaging we saw a dense mass, hypertense mass indenting the globe, and in the bony window we can see it's invading the inferior and the middle turbinates and extending into the nasal cavity. A biopsy showed an adenocarcinoma of the nasolacrimal duct and the lacrimal sac, involving the lacrimal sac. So this patient was taken up for neoadjuvant chemo, 3 cycles followed by surgery, and here we had to go ahead with a medial maxillectomy because there was bony invasion of the medial maxilla. And this is again a very interesting case of external angular dermoid in a middle-aged male who had previous surgeries and there was constant recurrence. The radiologist had reported just a cavitation in the lateral orbit. What the bone cuts revealed was and a communication through the bone into the temporal fossa. So this was actually a dumbbell dermoid which had been missed in the previous surgeries, and just an orbital excision was done without the curettage of the dumbbell part of the dermoid. So these are some of the subtle clues that CT provides us, which MRI may miss because bone could not be visualized. This is a tumor which lies in the gray zone. Here an internal angular dermoid was seen. We can see the bony remodeling on CT. However, we can see the superior oblique muscle and the tumor just touching the trochlea. In such tumors, an MRI would be a better option to rule out adhesions with the trochlea, and we can plan and counsel the patient accordingly for the management, because there is a chance of injury to the trochlea in such cases. There are some tumors where definitely MRI holds a precedence, like these pear-shaped lesions with phlovoids in between, where we would like to know how far or how close they are to the optic nerve, and accordingly we can counsel the patient regarding the approach for surgery and the possible visual outcomes. It turned out to be a cavernous hemangioma. Again, a complicated case, elderly lady with bilateral enophthalmos, known case of CA breast. She had bilateral orbital masses on MRI engulfing the muscles. She turned out to be orbital metastasis of the previously treated CA breast. And here actually the diffusion weighted MRI plays a really important role, because the absolute diffusion coefficient, as can be seen in this image, is comparatively lower than the orbital fat, which suggests a dense lesion suggestive of a neoplastic etiology. And then one of the last cases in this series, this was a patient of retinoblastoma, operated 2 years back elsewhere, given chemotherapy, enucleated, and the nerve stump, 10 mm nerve stump was taken, which was free. And last month she came to us 2 years after treatment, again with some complaints, and an MRI showed a mass growing at the optic chiasm into the cranium, and it turned out to be a recurrence. So this is one thing where MRI is a definite choice over CT. So I have some more, but I'll skip them because my time's up. So,
yeah, thank you so much.
Thank
you very much. Sir, do you have anything to discuss? Anything from the audience? Your view on CT scan and MRI. Who all does Orbit here? Yeah. So what's your preference in your practice? Yeah. Right. Right. I think we all agree with Dr. Shah that, this is how an orbital surgeon would want to navigate their cases.
I think the primary factor which governs my practice is the patient asks what will be the charge for each, and then they prefer, okay, I'll go for the lower expense. So I think whatever we discuss, finally it boils down to that in most of the cases.
Right, and I'm sure you do contrast enhancement for all the cases, and I think that is one of the most important thing. Yeah. So
any comments? Can I just?
Yeah. Yes.
Extent of the lesion, and they only come with CT scan. So
And
then you get stuck. So
so
they
actually
end up paying
it
for
shackles
two
up our
investigations.
options,
Yes.
right?
I think if the patient is coming to you like the first instance, then it is our responsibility to actually explain
tell them
to
the
them that
pros
this
and
is
cons,
more
right?
important. Especially, I feel like thyroid eye disease is one condition where you have to know when you need MRI with contrast and when you need CT scan. Sometimes for surgical planning, even in recurrent cases, or where you've done just one wall and you're planning for a medial wall, you've done just medial wall as an emergency, and now you need a lateral wall just for cosmesis. Over there, CT scan becomes more important. But if you're actually evaluating an optic nerve or an optic neuropathy, then MRI becomes very important. Or you are deciding on methylprednisolone and whether there is any kind of activity going on with the patient or not. then CT is less important and MRI becomes
Right,
more
I think he
important.
has highlighted that.
Yes,
Yeah,
actually, I had
thoughtfully well.
thyroid eye disease and fractures in the further slides,
Yeah,
but I
that's
could not
Sure.
Thank you.
complete
It
them.
was a very nice business.
Thank you.
We enjoyed
Can I just add one point which I think everybody can utilize? Near you all, whenever you're receiving the reports for CT and MRI, you all already know the diagnostic centers which are in your vicinity. Just give one call to them and ask them that if at all you get a patient with an orbital tumor or any periocular disease, please emphasize on doing it with contrast. Like I've done that for the people around, and then that saves the patient's money, because otherwise you have to send it back for contrast. So it's easier.
And I think one more thing we need to, focus is that we need to assess the DICOM images ourselves, because a lot of radiologists
Yes.
don't have much experience with diagnosing orbital lesions. I mean, they are very confident with CNS, PNS lesions, but orbital lesions, they somehow falter, where like the dumbbell dermoid was not picked up.
Absolutely.
So
I'm sure all the
assessing
orbital
DICOM
surgeons,
images is
all the
absolutely
orbital
essential.
surgeons sitting here, I'm sure you do your own reporting, yeah. And that is the most, because most of the time when we get a report from a radiologist, be it any lesion in the orbit, it's cavernous hemangioma. Right, yeah. Every report is cavernous hemangioma, yeah. So
Or a pseudo
or a
tumor,
pseudo
yes.
tumor, right? Yeah. So we all know that, and we have learned it, and yes, yeah. So let's go to the